Welcome back to Diabetic Food Files. I'm Dr. G, and today we're going to talk about a common silencer called lidocaine. I know sometimes we use it on wounds or to anesthetize the wound. Sometimes I'll do a block along the area so you can do a good debridement, right? Especially if it's extremely painful for the patient, or they will use gel, lidocaine gel, to penetrate, but it shouldn't really be used that much on open wounds, in my opinion. But let's talk about it because sometimes people can get what they call lidocaine toxicity, and people need to be fully aware of it because I think people think it's harmless just because it's a topical agent, and it's not. So let's get dive into it with diabetic foot files. So, how was lidocaine discovered? Lidocaine was synthesized in 1943 by a Swedish chemist called Niels Lofgren. I'm just going to spell his name Lofgren. And it was first marketed in 1948 under the trademark name Xylocaine by Astra AB. So before lidocaine, we used cocaine. Yeah, actually cocaine. I think everybody knows that. And then procaine, Novocaine. And lidocaine was revolutionary because it was more stable, it was faster acting, it was less allergic, allergenic, and it was more predictable. It became a prototype for amide local anesthetics. So let's talk about the chemistry of lidocaine and why it works. So lidocaine has three structural components. It has an aromatic ring, which is lipid soluble portion. That's its lipid soluble portion. It has an amide linkage, which determines its metabolism, and it has a tertiary amide tail, which is the water soluble portion. So literally, it has a lipid soluble portion, a water soluble portion. So the chemical formula of lidocaine is C14H22N2O. Okay, it is a weak base with a pKa of approximately 7.9. And forgive me if my voice sounds a little raspy. So why does pKa matter? So only the non-ionized, so the the uncharged form crosses the lipid membrane. And as the physiology is a pH of 7.4, about 25 to 30% is non-ionized, and that fraction crosses the nerve membrane. And then inside the axon, it reionizes and it binds to the voltage gated sodium channels and blocks the sodium influx, which prevents depolarization. So, no sodium entry equals no action potential equals no pain transmission. So, what exactly is lidocaine blocking? So it blocks the fast voltage gated sodium channels in the A delta fibers, which are the sharp pain fibers, and the C fibers, which are the dull burning pain. Okay. And in the heart, it actually works in the heart as well, right? It blocks the phase zero depolarization in the ventricle myocytes, so in the ventricle muscles. And this is why lidocaine is actually a local anesthetic, but also a class 1B anti-arrhythmic. Okay, so it stops the heart from going in arrhythmia. Okay, anti-arrhythmic. Forgive me for the mispronunciation. So, well, how can lidocaine become deadly? Because I think sometimes people hear little stories about like people using lidocaine for tattoos and they'll put it on their entire body and then the person ends up going into cardiac arrest and having lidocaine toxicity and everybody thinking that it's harmless because it's just a topical agent. They think it's like lotion, but it's not. It should be used under a medical professional, okay? Not just anybody should be using lidocaine because it actually can cause cardiac arrest. So this is where things can get serious, lidocaine toxicity. And anybody who's taken boards or, used SMLE step one, all the boards, you learn about lidocaine toxicity and learn how to calculate it, things like that, right? So they call it LAS, local anesthetic system toxicity. So this happens when too much of it was given. It's injected intravascularly if it's applied to an open large wound because like and an open large wound can also be like a tattoo because they're creating a wound, right? Because they're piercing into the skin, right? Used on a highly vascular tissue, used in liver dysfunction, or used in an elderly person or person with low body mass. So how do we calculate the lidocaine toxicity? Okay, this is helpful because you have to also remember lidocaine presents with epinephrine or without epinephrine. I always use the without epinephrine because that's the safe. But so without epinephrine, the maximum safe dose of lidocaine without epinephrine is 4.5 milligrams per kilogram. Okay, so mg over kg. But with epinephrine, the maximum dosage is 7 milligrams over kilograms. Okay. So why more with epinephrine? Because epinephrine causes vasoconstriction, which slows the systemic absorption. So let's give a quick example. Let's say the patient weighs, and I hope y'all are listening who takes the boards, like step one or step two, things like that. So the patient weighs 70 kilograms. So the maximum dosage of lidocaine that can be given to a patient who weighs 70 kilograms, it's going to be, this is how you calculate it because your board's definitely going to ask this, 4.5 milligrams times 70 because it's 70 is over 70 kilograms, right? And so the maximum dosage is 315 mgs. So what if you're using 1% lidocaine? 1% lidocaine is 10 milligrams per milliliter, right? So then you do 315 divided by 10, and that gives you 31.5 ml is the max dose. Okay. So imagine someone just, hanging lidocaine over a large wound. Let's say they use 50 mLs of 2% lidocaine. 2% lidocaine is 20 mgs, milligrams over mLs. Okay. So it would be 50 times 20, which is 1,000 milligrams. That is 3 times over the safe dosage. And this is happens because an open wound has exposed capillaries. Open wounds usually have inflammatory vasodilation. There is no intact epidermal layer because it's a wound. The wound doesn't have the epidermis. Okay. The absorption becomes quite rapid and quite unpredictable. And that's how some patients can go into the seizure or cardiac arrest. So, what does lidocaine toxicity look like? So the early central nervous system symptoms are perioral numbness, like their mouth starts feeling numb, metallic taste, tinnitus, agitation, tremors. What are some of the late central nervous systems of lidocaine toxicity? Seizures or coma. What are some of the cardiac symptoms? Bradycardia, QRS widening, ventricular arrhythmia, cardiac arrest. Okay, because it depresses the heart before it stops it. So bradycardia, it slows the heart before it stops it. So why what we call in quotation hanging lidocaine on an open wound is dangerous. That's why it should be used by health professional, actual health professional, healthcare professional. So in wound care settings, some providers soak gauze in lidocaine, right, and leave it on the wound and let it sit. But they have to use precaution when it comes to that because how is it dangerous? Because it's open tissue. There's direct vascular access. And the inflamed tissue means there is increased perfusion along that area. And like we said, this is an open wound, so there is no epidermal barrier. And the surface area matters, and repeating the dosage accumulates. So this is particularly dangerous in patients who are diabetic, patients with liver dysfunction, elderly patients, patients with low albumin, and patients who have peripheral vascular disease. So remember, lidocaine is 65% protein bound. So low albumin means more free drug. So why does the VA and ACLS, and everybody got their ACLS certification, right? Their advanced cardiac life support uses lidocaine. Why do they use lidocaine in ACLS, advanced cardiac life support protocols? So lidocaine is used as a class 1B antiarrhythmic. Okay, so it's used for ventricular tachycardia and ventricular fibrillation. It's an alternative to amiodarone. So why? It preferentially binds to ischemic ventricular tissue. So it shortens the action potential during the damage. They shorten the action potential duration in the damaged myocardium. So this is helpful in a post myocardial infarction ventricular arrhythmias or if there's electrical instability. And in veteran hospitals, historically have used it frequently because many patients have ischemic heart disease and it's widely available and is actually cheaper than newer antiarrhythmics. And I'm saying it wrong, but anti-arrhythmias. Okay. So why are wounds so painful? Because we all know wounds are painful, right? But one thing I have noticed that the wounds become less painful as the wound closes, as the infection leaves, as the confusion gets better, things like that. So inflammatory mediators. So like prostaglandins, bradykinin, substance P, TNF alpha, IL-1, these lower your nociceptors thresholds. Next is tissue hypoxia because everybody knows like arterial ulcers or ischemic tissue is extremely painful. That's why the people are going to just have rest pain, right? Ischemic tissue produces lactic acid as well as reactive oxygen species, which causes pain. Okay. Then infection. We know infection is extremely painful, even if you have like a little ingrown, right? And it becomes infected. That's why it's so painful as well. So bacterial toxins actually stimulate the nociceptors, okay? And then exposed nerve endings. These are open wounds, right? So they depending on the depth of the wound, they become to have exposed nerve endings. So particularly debrided wounds or neuropathic wounds with partial nerve innervations or edema, swelling. So increased interstitial pressure stimulates pain receptors as well. So what are some safer alternatives to numb a wound? Instead of pouring lidocaine on the wound, right? You can use a buffered lidocaine injection. So add sodium bicarbonate, which reduces the injection pain. And this is for healthcare providers only. This is not for anybody to use at home, okay? Uh, I know sometimes they have lidocaine gel over the counter, but I hope people hear this that you should not honestly should be using under a healthcare professional. It actually is quite dangerous to use just freely. It is not lotion. Thank you. So next, you can do a regional nerve block, okay? I do like a popliteal block if it's below the knee, right? You can get an anesthesiologist to do it too. Posterior tibial block. Why would we use a posterior tibial block, right? If the wound is at the plantar aspect of the foot. Like I said, I remember residency, my attending, there was a patient with a very painful wound at the plantar aspect of the foot. He said, do a PT block. I was like, oh, why? And he said, yeah, that's the whole bottom of the foot. Yay. Okay. Thank you, my attending. Digital block. Great digital block. Let's say the painful wound is at the tip of the toe, right? Like a hammer toe. Yeah, I love me a digital block. Very easy, very simple. Get those 4 points and you're good to go. Okay. But you can control the dosing with a regional block. Next, topical LET gel for superficial wounds. So honestly, I don't use lidocaine with epinephrine because it causes vasoconstriction, right? And with the type of patients we deal with, their vascular system is very compromised, so you don't want to take chances, okay? So I would leave that to the experts, okay? Elma cream. Elma cream is lidocaine plus prilocaine. Works very well. Okay. Use cautiously on intact skin only. Okay. Works very well, but it's only under prescription. Okay. So only should be used by a healthcare professional who's well versed in that. Okay. Vapor coolant spray, like a brief superficial anesthesia, like what's it called? Ooh, that we use before injection. Oops. I think y'all know, but it's a vapor coolant spray, right? It uses ethyl glycol spray, so it cools the area like it ices it out. Next, systemic analgesia. It's like using acetaminophen. I know that they've had precautions with that now. NSAIDs, if they or short-acting opioids for procedural pain, but I leave opioids to pain management. That's what I do. Okay. Sometimes they use ketamine. I remember one time during rotation, is it SF General? It was a little girl who a finger got stuck into a mattress while her parents were moving, so the finger got stuck at the fold-up mattress, and her finger got stuck, and it pretty much fully amputated, right? But it was holding on by a thread, and they sewed it back, but they put the patient on ketamine, so she was in a dissociative state while they were sewing it back, okay? But honestly, she did not feel anything after that thing was almost fully amputated, but I did not see if the reattachment took, but the doctor, ER doctor did a fantastic job, so hopefully it did take, okay? But sometimes it requires microvascular surgery. And then proper offloading, okay? So pain from pressure wounds decreases dramatically when pressure is removed. I remember a patient is experiencing a lot of pain from the plantar wound, put them in a big, heavy cam boot, no more pain. Simple as that. Voila. And he said he didn't even need the pain medication, which I what NSAIDs, but he said he didn't need it, okay? So, what are some pearls to remember from this episode? Open wounds do not behave like intact skin. Okay, that's why it's an open wound. It does not have intact skin, does not have all the layers of the skin. And most of all, it doesn't have the epidermis, okay, if it's an open wound. So, transdermal absorption is dramatically increased when the stratum corneum is absent. Okay, that's first layer. Tissue is inflamed when surface area is increased and occlusion is present because sometimes they like to wrap it, right, for the absorption to be better, but that can dramatically increase it as well, okay? And what is the stratum corneum? I hope everybody remembers that. That is the dead keratinized layer. That's the primary layer. That's the most superficial layer. Then we have the stratum luteum, we have the stratum granulosum, we have the stratum spinosum, which is the spiny layer, prickle layer. Dermatomes connect to the keratinocytes. Stratum spinosum has the Langerhans cells, thank God, and immune, which are the immune defense. And this layer is metabolically active. Okay, keep that in mind. And so, what is the relevance of knowing the different layers? Superficial wounds, only the epidermis is affected, right? So, minimal vascular exposure. So, a topical absorption is limited. When it's a partial thickness wound, that means it extends to the papillary dermis. So, now the capillaries are exposed and drug absorption does increase. For full thickness wound, that means it's through the dermis, correct? So there is direct vascular access, there's no barrier, there's high systemic absorption risk. This is why pouring lidocaine into a diabetic foot ulcer is not the same as putting Elma cream on intact skin. So please use with caution and think about systemic toxicity. Okay? And so, what to do if lidocaine toxicity does occur? Okay, treatment for lidocaine toxicity is airway support, benzodiazepines for seizures. So you're gonna need the patient needs to go to the ER. Okay, pretty much. ACLS protocol and IV lipid emulsion therapy. And why does lipid work? Because they create a lipid sink, and this lipophilic lidocaine partitions into fat droplets in the plasma, and this reduces the free serum concentration. So, as you can see, chemistry stays alive, as always. So, in the end, I hope people understand this. But also, hold on, let me get a little bit also into arterial ulcers because sometimes, we already know arterial ulcers are dry, ischemic, punched out, and usually distal, right? So, the biochemical environment of an arterial ulcer is severely hypoxic, low perfusion, low pH because it's acidic from anaerobic metabolism, lactic acid accumulation, reactive oxygen species, and low exudate. Arterial ulcers have low exudate. Remember that, okay? And so, what does that mean if you use lidocaine on an arterial ulcer, right? It has an acidic pH, so more lidocaine becomes ionized. The ionized form cannot cross the membrane well, so it reduces the anesthetic effect. It has low perfusion, right? Because there's no good blood flow, so the slower systemic absorption. So it has an unpredictable pooling, okay? So the drug can still sit locally and then suddenly absorb when the perfusion improves. We don't want that. And then hypoxic nerve fibers. So ischemic nerves are already dysfunctional. So the sodium channel density may be altered, the aesthetic effect may be inconsistent. So what is the result of that? You can end up having often poor numbing effect, risk increase if reperfusion occurs, like a sudden systemic absorption, and dangerous in a revasculated limb. Now, venous leg ulcers, the ones that are edematous, exudative, and inflammatory. So the biochemical environment of this venous leg ulcer is chronic inflammation, high interstitial pressure, increased capillary permeability, high protein exudate. Venous leg ulcers also have elevated cytokines, but which wound doesn't, right? But TNF alpha, IL-1, and MMPs, which are matrix metalloproteinases, and the pH often mildly acidic but varied. Okay, so what does that mean if you use lidocaine on a venous leg ulcer? The high protein exudate. So, like we said, lidocaine is about approximately 65% protein bound, right? So more binding to the albumin in the exudate. There's less free drug initially, but binding is reversible due to the delayed systemic absorption. There are leaky capillaries, so there's increased systemic uptake, which makes the risk for toxicity higher. The edema, the swelling in the leg, dilutes the drug concentration, may require more to achieve the effect. There is a risk of overdosing. Chronic inflammation, the sodium channels are upregulated, the nociceptors are hypersensitized, and the higher aesthetics requirements. So, clinical result of that, you may require more of the drug to achieve actual anesthesia. There's a higher risk of systemic absorption than arterial ulcer, and the larger the surface area, the higher the increase of toxicity potential. Now, for diabetic foot ulcers are the neuropathic ones, infected ones, metabolically unstable. Okay. So these are the ones that are most likely clinically or chemically complex as well. So the biochemical environment of a diabetic foot ulcer, you have what we call AGEs, which are advanced glycation end products. You have oxidative stress. You have peripheral neuropathy, you have microvascular disease, you have frequent infection, you have biofilm formation, which is pretty much inevitable a lot of times in diabetic foot ulcers, impaired immune response, and a variable pH, often alkaline in infected wounds. So why is pH an issue? Because remember, normal pH of skin is actually acidic, normal skin, okay? But an infected diabetic wound is often shifted to an alkaline pH, which is going to be about 7.5 to 8.5. So remember, the higher the pH, the more non-ionized a lidocaine that is. That means there is increased membrane penetration. So paradoxically wise, the lidocaine may absorb more effectively in an infected diabetic wound, which is kind of crazy, right? But you have to remember protein binding changes. So diabetics often have hypoalbuminemia, right? Renal disease and liver dysfunction. So less albumin means more free lidocaine, which means decreased toxicity increases, right? And then you have to also remember with diabetics, they have neuropathy. So in neuropathy, the A delta and the C fibers are damaged. So the sodium channel expression changes in those, okay? And pain may come from a deeper ischemic tissue instead of a surface nociceptor. So topical lidocaine may not relieve deep ischemic pain, okay? May lead to repeated dosage, but we don't want, and can increase systemic load. Now, also the other thing we have to think about and tackle is the biofilm. Biofilm alters pH inevitably, alters the oxygen levels because you already know biofilm is created by the bacteria. It makes it impermeable to antibiotic resistance, allows it to have a little safe haven and continue to replicate and multiply, right? Biofilms also contain their own bacterial sodium channels and can trap medication. So lidocaine can partially diffuse if there's biofilm present and it won't be able to deeply penetrate. So I hope everybody found this episode helpful. And what is the take home message? Lidocaine is very helpful. It's brilliant. It's elegant. It's chemically precise, but it's not harmless. Okay. It blocks sodium in nerves. It blocks sodium in the heart. It blocks sodium in the brain. So too much of it, the nerve goes quiet. The brain sees and the heart can't stop. So I want everybody to keep aware of all the risks and benefits whenever using any type of medication. And this is Diabetic Cook Files. This is Dr. G. Toes tell the truth and take care of your feet because they take care of you.